Hello, my name is Siddharth and today I am going to talk about ultrasound guided axillary brachial plexus block. As we all know that axillary approach of brachial plexus block is utilized at the level of axillary region, and this approach target individual nerves that are musculocutaneous nerve, median nerve, radial nerve and ulnar nerve. So the cords they divide into the nerves and they form the nerves, and these nerves are actually targeted in axillary region by the approach of known as axillary approach. This approach is indicated for the surgeries of generally surgeries below elbow, forearm and hand surgeries, and it can be used as a rescue block when the proximal approach of brachial plexus block are failed, like when supra, infra or interscalene. When they fail, you can utilize axillary approach as a rescue block. This is the cutaneous innervation of the axillary approach. Again, you can find the areas of musculocutaneous. This one, this is radial now on the posterior side, and this is ulnar radial. Again, some sort of median. This is axillary nerve area, which is not blocked by the axillary approach, and you can find this is musculocutaneous, again ulnar and median nerve, radial nerve. Okay, so now let's talk about USC settings. That mostly the patient lies supine with arm abducted positions, and in that generally utilized probe is high frequency linear probe because it is superficial block, and inline approach is commonly utilized with a depth setting of 2 to 3 centimeter, and needle generally I utilize is 2.5 to 5 centimeter short bevel PNS needle, and dose the require that is 5 ml per each nerve. There are 4 nerves targeted over here: musculocutaneous, median nerve, ulnar nerve and radial nerve. So the total volume generally I utilize is a 20 ml per block. So when we put a high frequency linear probe over the axilla, the targeted structure will be like axillary arteries, axillary vein. There may be a 2 to 3 in number, uh, axillary artery, and somewhere here you'll find the biceps and the coracobrachialis muscles, and in between these two muscles we'll find the musculocutaneous nerves. On the superficial you will find the median nerve, and in between the axillary artery and axillary vein we will find the ulnar nerve somewhere here, and posterior to the axillary artery we will find the radial nerve, and this is conjoint tendon. Okay, and this is part of humerus. So the ultrasound picture will look like this. See, this is biceps muscles and this is coracobrachialis muscles, and in between these two muscles musculocutaneous nerve is there. This is axillary artery. So the first important landmark is the axillary vessels over here. When you find axillary artery over here on the screen, keep it on the middle of the screen, and try to see on laterally in between these two muscles you will find the musculocutaneous. That's a it's a slit like opening, oval shape. It looks like a bullseye like, and somewhere here on the top of the axillary artery you will find the median nerve. On the medial side you will find the ulnar nerve, axillary vein that can be confirmed by the compressibility test, and posterior to the axillary artery we will find the radial nerve, and that lies over the conjoint tendon, this layer. So this act as a landmark one again, because you are not going deep to this. You have to inject the drug somewhere over here, just above to this tendon. Okay. So this is the sonoanatomy. This is lateral side. This is medial side, or we can say this is superior side or lateral side. And you will find the musculocutaneous over here, median nerve over here, ulnar nerve will be somewhere here, and radial nerve will be somewhere here. Okay. So again, this is median nerve, the yellow mark, median nerve, ulnar nerve, radial nerve, posterior at 6 o'clock position. Okay, and musculocutaneous nerve in between the bicep and coracobrachialis muscles. Okay, let's see some screenings. In that, when you apply high frequency linear probe over the axillary region, the first important landmark is axillary artery, and when you try to see on the lateral aspect, this is bicep, this is coracobrachialis muscles, and in between these two muscles you will find the musculocutaneous nerves. Thus, see. So this is slit light opening is this is median nerve, ulnar nerve, radial nerve, just posterior to the axillary artery. Sorry, some disturbances in video. So let's again see the musculocutaneous. See in between the biceps and the coracobrachialis, we'll find the musculocutaneous now. This is we are going from proximal to distal, and now we are going distal to proximal. See, it goes near to the axillary artery and distal to as we go respectively. See. This is proximal one, and see it is going near to the axillary artery, and when we go distally it actually separate, and it lies in between the biceps and coracobrachialis artery. So the most of the time we can visualize this musculocutaneous nerve very nicely. So it's very easy to identify the nerves. See, when you go distally, it goes in between the two muscle layers, and when we come proximally, it will be nearer to the axillary artery. Median nerve. Nerve lies on the top of the axillary artery, and when we go distally up to the elbow, it flips and it become lateral to medial. See, this is medial, and again come back to the proximal side. Then again, the same thing, the flip will be there. So median now, the characteristic is it lies along with the axillary artery. Number one, it lies all the part from axilla to the elbow, and it actually flip from lateral to medial. When we go from axilla to the elbow, uh, the median nerve flip from lateral to medial sides. So it is when you can't identify the nerves individually, uh, the tracing technique is the only confirmatory technique, because through which you can identify the different nerves, and the peculiarity of the median now is that it lies along with the axillary artery and it flips from lateral to medial. Let's see ulnar. Ulnar actually separates and it goes to the median side. See, somewhere here we'll find the median is separating from the axillary artery and it is encroaching. It is going to reach up to the medial epicondyle of the humerus. See this one. So keep eyes on the nerves. It will goes very near to the very near to the lower end of the humerus, that is medial epicondyle when we go from proximal to distal. See, now again we are going back from elbow to axilla, and it will the nerve tissue will lies in between the axillary artery and vessels somewhere here. So this trace back technique is very important to identify the individual nerves. Here we are talking about the ulnar nerve. Now let's talk about radial nerve. Radial nerve lies posterior to the artery, and it is many times for many consultants it is difficult to identify. See, at this level we can very well visualize the radial nerve over here. This is and when we go distally, it going in a radial groove of the humerus. So this is slit light. This nerve is a radial nerve, and when we come proximally, it actually when we goes proximally, it actually going to be posterior to the axillary artery somewhere here. So here we are tracing only up to the mid-arm because it actually curves through the radial groove. It actually curve the humerus bone, and so that the scanning is little bit difficult in those things. So this is only up to the mid-arm. So from axilla to the mid-arm. Okay, now the anatomical variations there are in specifically in positioning of this different nerve in relation to the axillary artery. So let's see those things. See, the median nerve lies. See the all four figure or 4, 1, 2, 3 and 4. See the position of medial nerves in respect to the axillary artery, and it is mostly superficial to the artery. There are less variation for the median nerve actually, which lies on the superior quadrant all the time. See, this is median nerve. Okay, then this is ulnar nerve, yellow color. See, yellow blink is ulnar nerve. See the positions. It is some changes with the axillary vein, somewhere here, somewhere here, somewhere here. Okay, now let's talk about radial nerve. See the radial nerve positions. And this is musculocutaneous. See, musculocutaneous now. So I feel that musculocutaneous variation is very much high, where the radial nerve variation is high. Okay. So the traceback technique is actually going to help you. Now let's talk about how to block, how I block the axillary approach. So mostly from head end, I start with the lateral to medial approach, and mostly I finish the block with with single skin puncture. So for my first target is mostly from far distance, and I'm going more horizontal to the probe, and my first target is a musculocutaneous nerve. See, these are the nerves target. Musculocutaneous nerves is this is median nerve, this is ulnar, and this is radial. So my first target is musculocutaneous nerve in between the biceps and coracobrachialis, and second time I redirect my needle with the same skin puncture. Just I am redirect and goes mostly toward the median now, and I separate median nerve from the axillary artery and I goes up to this region and I deposit few drugs over here. So somewhere here I will finish 5 ml, somewhere here 5 ml, and my needle goes up to this region, and I again target few 1 to 2 ml for over here, because that will separate this area also. And the third injection is below the axillary artery to cover the radial. Okay, now I keep more eyes over here because these two nerves should be targeted more cautiously because they can be spared. See, this is the end point of conjoint tendon, so this is margin. So many times I dissect from this area and I deposit few drugs, and I many times this depress the axillary artery and reach up to the ulnar nerve, and maybe up to the radial nerve. If radial nerve is not not covered by this injection, then I redirect third time to cover up the radial nerve lying on the posterior to the axillary artery. So in all time my skin puncture from far distance is remain same. So from a single skin puncture I deposit musculocutaneous, then median nerve, then try to cover up the ulnar nerve on the top, and maybe some part of in that radial by depressing the axillary artery on the conjoint tendon. Or if that is not possible, then I third time I redirect to cover the radial nerve just going below to the axillary artery, and I deposit few drugs over here. So each nerve 5 ml target and 20 ml will be the total dose, and all time I remain superficial to this conjoint tendon. So this is my personal technique, my personal view. Okay, now let's see the some block. See, this is targeting the musculocutaneous now, and I'm going hydrodissection over this musculocutaneous now. See, few ml is injected, and this will be less than 5 ml. See, this is musculocutaneous now in between the biceps muscle and coracobrachialis muscle. This is axillary artery. After finishing this block, I am approaching with the same puncture to the median nerve somewhere here, and I'm trying to separate the median nerve and from axillary artery. See. So median nerve, I'm trying to be in between these two structure, axillary artery and median nerve, and I will start injecting few mLs. Okay, so I'm just going in between the median nerve and the axillary artery, and I'm now targeting on the ulnar nerve and radial nerve. See, see, there are few nerves over here. If you can see, this is a median cutaneous nerve of forearm. This, okay, and this is what I am targeting is a ulnar nerve, and this is the conjoint tendon. See, and because I am depressing the axillary artery, I may encounter the radial over here. So here I have taken only two redirections, and by pushing the axillary artery, the radial nerve will come into the picture on the second directions. Okay, let's see some more pictures. See again, this is musculocutaneous now. The nerve, my needle is encouraging, pointing on the musculocutaneous now. First, uh, 2 to 5 ml drug is a volume, undiluted. So I'm going to hydrodissect to reduce the volume. See, this nerve portion is separated from the surrounding tissue. You can very well visualize. and this will give you a rapid block actually when you do such kind of hydro dissection, but it's not necessary. You need to be, you need to take caution not to damage the nerve. See, the next target is median nerve, and this is not the same patients. Let me clear it. It's targeting on the median nerve, ulnar and radial. All the nerves lies over here. Somewhere here you'll find the axillary artery, which is push up, push down, and this is conjoint tendon. See, by pushing it, I am nearly in between the same plane. Like this is radial, this is ulnar, this is median, and the artery is just on the conjoint tendon. See, this is radial. Now I am targeting. So I have taken only two. This single direction, single redirection will block median, ulnar, and radial. Now, see, if something is still escaping, then I mostly redirect posteriorly to the artery and try to cover up the radial now. See, and conjoint tendon. Okay, clinical falls. Avoid excessive pressure by the USC probe because that can alter the spread and that can increase the chance of IV injection. And if you can't see a drug coming out in the picture, then it might be possible that you are injecting the drug into the vessels, mostly veins. So beware of these things. Every time you should visualize the tip and the drug, whatever you are injecting. So I generally use single person technique. I scan and I personally inject. Frequent aspiration and slow injection is a all only remedy, and use PNS for the safety because these are the individual nerves and they can be damaged. So take care. Thank you.